Can I just make one housekeeping? If everyone could mute themselves before Dr. Brewer starts speaking, otherwise it gets really distracting. I see that there's quite a few people that are not muted right now. That'd be great. Thank you.
Thanks for doing that. Okay. We are happy to have Dr. Joseph Brewer here with us this evening. And for those of you here in the Kansas City area, we know that he has been the infectious disease expert in our area, and he understands the struggles that we all have had through with Lyme disease. Dr. Brewer is an infectious disease specialist with St. Luke's and practices at St. Luke's Hospital here in Kansas City. He's an assistant clinical professor of medicine at the University of Missouri, Kansas City School of Medicine. Dr. Brewer is involved in clinical teaching at St. Luke's and UMKC. He has been in practice for over 40 years, including clinical practice of infectious disease, teaching responsibilities, and clinical research. He has had a long-standing interest in chronic illness patients, including chronic fatigue syndrome, Lyme disease, and similar chronic conditions. His practice has been very busy over the years, and I know that some of you have not been able to see him as he has many patients. We hope that this presentation this evening will give you some hope, and we invite you to ask questions at the end. If you don't mind, please put your questions in the Zoom chat, and I will read them so to save some time, as I know some of you will want to ask specifics. Thank you, Dr. Brewer, for your time, and we appreciate you. And at this time, I'm going to turn it to you.
All right, thank you. Can everybody hear me okay?
I can.
I'll assume that's a yes.
Yes.
So this is, I've titled it Lyme Update 2025. As it turns out, there's been some really excellent research in the last 2 years, 1.5 to 2 years, regarding Lyme disease, and particularly chronic Lyme and or so-called post-treatment Lyme disease. And so I'm going to go through that tonight and give you some details from published literature about some exciting new developments with Lyme. Okay, so most of this is going to focus on post-treatment Lyme disease, what's called PTLD, which to me is the same as chronic Lyme disease. So by the end of this talk, you'll probably understand that there are 2 pathogenic causes in which it's directly related to the Borrelia bacteria. One is persistent infection with Borrelia burgdorferi, which is not eradicated with antimicrobial therapy or antibiotics, particularly monotherapy, and that'll make more sense as we go through it. The second one, many of you may have not heard of because it's very recently published, is persistent peptidoglycan release from the bacteria that's retained in the body and leads to ongoing chronic symptoms. And the other is both. This will make more sense as we go through the talk. Whoops. So this is the first article we're going to spend a fair amount of time on. A lot of these studies have been mouse studies, but I call this the mouse combination treatment study. So this study, as you can see, was published about 2 years ago, November 2023. I didn't come across this article till about 6 months after it was published, maybe 8 months. And so I've been telling people about this for about 1.5 years. The main group of authors here are from Tulane University in New Orleans Medical School. I keep hitting the wrong button, sorry. So the rationale for, and this comes right out of the paper, the rationale for studying these combinations, and what you'll find is combination therapy can work to eradicate Lyme disease, at least in the mouse, and monotherapy does not work. So Post-treatment Lyme disease occurs in about 10 to 20% of patients who acquire Lyme disease. The failure of antibiotics to eradicate Borrelia burgdorferi infection is proposed as an explanation for PTLD. Guidelines for Lyme disease treatment uses single antibiotic agents. All of the published guidelines say you just need a single antibiotic and it'll take care of it, or what the authors of this paper call monotherapy. The Infectious Disease Society of America, as well as other international agencies, recommend either doxycycline or amoxicillin. Obviously, there's other choices too, but that's their official recommendations. And as you would guess, these are pretty old recommendations. And no surprise to a group like this, delays in treatment increase the likelihood of PTLD. So going on with the rationale for studying combination therapy studies, some of which were done by the Tulane group in mice, dogs, and non-human primates such as monkeys, shows persistent infection of Borrelia burgdorferi after treatment with doxycycline or ceftriaxone, which is Rocephin. So, and this would be receiving them as a single agent. And they basically fail to clear the infection after being treated with either doxycycline or ceftriaxone. Now, I'll mention later on when we get into the meat of this study that they did not study doxycycline and ceftriaxone in this particular mouse study because they'd already studied it before and it failed as a single agent. And you put them in combination, that's a different story. In vitro studies, which means test tube studies, have shown improved efficacy with combinations of antibiotics. There are some small studies in humans of a combination of antibiotics, usually IV combinations, that have been successful. For example, the one listed here is daptomycin, ceftriaxone, and doxycycline. The problem is ceftriaxone is not even available on the market anymore, and daptomycin is very expensive, and I can't imagine there's an insurance company on earth that would cover it. So also we can turn away from Lyme and look at other infections that are persistent, like tuberculosis, brucellosis, and there are other examples such as Q fever and others. And combinations have been shown to eradicate, for example, tuberculosis when single agents fail. So there is precedent for using combinations in other types of infections. Okay, so how did they do this study? So they basically took a large group of inbred laboratory mice that had never been outside of the laboratory. So there's no way they could have been infected or exposed to Lyme. And they injected these mice with a BB strain called 835. The infection was, so they did nothing for a month, and then they tested the mice by either ear biopsy, serology, or both. And 100% of the mice were infected. So then they waited another month and then started the treatment. So the treatment was administered, and I'll show you what the treatments are on the next slide or two. The treatments were administered for 30 days. And then the mice were divided into groups of 5. Well, to divide them into treatment groups, they were each in groups of 5. So there were 2 or 3 control groups, which I'll come back to, which is an important part of this. And then there were 8 single agent treatment groups. So if you wanted to say A through E or whatever, were a single agent by itself. And then there were 11 treatment groups that were combinations. Some of these were 2-drug combinations, some of them were 3-drug combinations. Keep doing that. So here's the list of the single agents: azacilin, Bactrim, disulfiram, etc. Now, some of these are antibiotics that you've never heard of. And you can say, well, why in the world would these be tried for Lyme? Well, It's actually bullet point number 3 there that, or no, I'm sorry, number 2. These were specifically selected because these agents have been shown either potentially or theoretically to be effective in persistent infection, even as a single agent. So they combed the literature to see what had been tried in the test tube and so forth, and what some other doctors have been trying to see if they could clear Lyme disease. Note loratadine, which is Claritin, is not an antibiotic, but in the test tube, it had shown some activity against Borrelia. And then the combinations were several combinations of the above, except in the combination study, they did also use doxycycline and ceftriaxone. Remember, they were not used in the single study. And then I've already addressed that last point there, that the authors didn't study doxycycline or ceftriaxone because they'd already studied them previously and they failed as single agents. Okay, so following the 1-month course of therapy, the mice were observed for another 2 months. Then they did 2 different sets of testing on them, and this is the meat of their how they found out whether the mice were still infected or not. Now, the first is called xenodiagnosis, and that's not as fancy as it sounds. Basically, they allowed ticks, and these were ticks that were born and bred in the laboratory. They allowed ticks to feed on the mice, and then they midgut tested them. They dissected the ticks open and looked in their midgut, which is where Borrelia hangs out inside the tick. And they used multiple different methods to see if the mouse transmitted the Lyme disease back to a tick. They didn't start with ticks, they just injected the mice to begin. But if these mice had Borrelia in their blood, then the ticks would bite them, become infected, and they would find them in the midgut. Now, IFA is indirect fluorescent antibody, so this is a specific antibody that stains positive for Lyme disease. It's about like doing a culture. Culture you see is on the far right. They did 2 different kinds of PCR. One is just standard DNA PCR, because Borrelia is a DNA bacteria. And the other is called reverse transcriptase PCR, which is similar to like COVID tests and so forth. Then after they did that, then the mice were euthanized at about 5 to 6 months after the original infection was induced with the injection. Then multiple tissues were examined by PCR, reverse transcriptase PCR culture. Now I've got listed there the tissues that they tested: ear, which is sort of like the skin, heart, spleen, urinary bladder, and joint tissue. Now this slide is pretty heavy, so I'll kind of walk you through it. So if the tick, when they allowed the ticks to feed on the mice, if the tick was positive in their midgut by either culture or the immune fluorescent antibody, the treatment was deemed to be ineffective because you found Lyme. If the tick cultures were, or the IFA was negative, then they went to step 2 and 3. So then they went to tissue. So now they euthanized the mice and tested all those organs that we talked about. And they tested them by culture and the PCRs as mentioned there. If any of them were positive, the treatment was ineffective. If all were negative, so everything had to be negative, the treatment was effective. All the tissues, all 5 mice, every method tested. So the tissue cultures, if they were positive, this is sort of saying the same thing over again. If the tissue cultures were positive, they were meaning that you've actually cultured Borrelia out of the mouse, it was deemed ineffective. If the culture was negative, they went on to the next step, which was DNA or RNA detection. If either of those were positive, the treatment was ineffective. If all were negative, the treatment was effective. Now, to summarize briefly that complicated set of events there, as you can tell, this is a very detailed study. I tell my patients in this particular study, the bar was very high. So to be completely effective in eradicating Borrelia infection from the mice in any of the groups that they tested, it had to be all 5 mice were negative by every method, including xenodiagnosis, by the ticks, culture, and PCRs. So everything, every way they look, from forwards, backwards, and inside out, for the bacteria, they all had to be negative for it to be deemed effective. Okay, so what did they find? I'll come back to this first bullet point in a minute. All infected, untreated control mice, because remember, there was a control group that got like saline water, and they didn't get any effective treatment. All untreated control were persistently infected, so all of them were positive at the end of 6 months. All monotherapy failed to eradicate persistent Borrelia infection. Now, some of the monotherapies, meaning a single agent, were actually what I would call partially effective. And what we mean there is it did not eradicate infection in all 5 of the mice in that group, but it did in part of them. So for example, maybe 2 would have been cleared of infection by all methods of testing, but the other 3 were not clear of infection. So I think this is similar to what we see clinically, where some people can take an antibiotic by itself, a single antibiotic like doxycycline or a cephalosporin, and they get over the infection, whereas other people do not. And I have no idea why this occurs in the mice, because remember, these mice are inbred in the laboratory, so they're they're not twins, but they're very closely related. So if it's genetics, there can't be too much difference in the mice. Now, several of the combinations, the majority of the combinations were not successful. They could not eradicate the infection. However, several combinations did successfully eradicate the infection in all 5 mice in their group. So the first one there is the most important one, which I'll come back to. Ceftriaxone, which is an IV cephalosporin that's no longer on the market in the United States, but we have others that are equally as good. Or ceftriaxone, which is Rocephin plus doxycycline, completely eradicate the infection in all the mice. And then they did the above with this antibiotic that's not even on the market called carbamycin, dapsone plus rifampicin, dapsone plus clofazimine. Now, for example, clofazimine, you can say, I've never heard of that before. Don't feel bad. Most people haven't. Many doctors haven't even ever heard of it before. Clofazimine is very hard to get. You can only get it through CDC, and it's for leprosy. It actually turns out it does work for Lyme in combination with dapsone. Both of those antibiotics have lots of side effects, and it would be almost impossible to get clofazimine for Lyme. So that's why I'll keep coming back over and over again. The main regimen that this study brings forth that would be effective is a simple regimen of a cephalosporin that works for Lyme plus doxycycline. And I'll show you in a couple of slides what we've used. So what can we say? What are the conclusions of this therapy of combination therapy versus monotherapy? Monotherapies do not clear or eradicate infection in at least all the mice. Remember, some of the agents, like some of the cephalosporins, would clear it in about a third to half of the mice, but not all of the mice in the group tested. Others failed in all 5 mice. Various antibiotic combinations do clear and eradicate the infection in all of the mice that were treated. By far the most practical and clinically useful combination would be that of a cephalosporin, and this can't just be any cephalosporin, it has to be one that's known to be active against Lyme, and doxycycline, those two taken together. And then again, I'll point out that infected, untreated controls all remained infected, which tells us that the mouse, murine means mouse, the mouse immune system did not clear the infection. So that once those mice were infected, presumably they'd be infected the rest of their life. Okay, so as I mentioned earlier, I've been dealing with this for about a year and a half now. So I've been telling patients about it. Most of them are eager to try it if they have chronic symptoms. And I've used one of two oral cephalosporins, either ceftriaxone, which is the generic name of Ceftin, or cefpodoxime, which is the generic name of Vantin. Both of those are sold generic. And then, of course, pair it with doxycycline. The treatment duration's been all over the place. I've had some people who only took it a month, just like the mouse study. And I've had other people who stayed on it about a year. I would say the average, I'm just kind of guessing, but this is pretty close to probably what it really is about 4 to 6 months on therapy. We don't have any magical tests to tell them. I tell my patients somewhat humorously that we're not going to do an autopsy on them to see if they've cleared the infection. So we don't really have any standardized, well-documented blood test. I know there are blood tests out there like cultures and so forth, but they've not been rigorously tested. And so basically we are basing everything on symptoms. So for this slide, I just said improving or resolution of symptoms. The majority improved. I would say at least 75% have improved. And many, maybe as up to 50%, have had complete resolution of symptoms. The next one is very important because I have tons of patients who took Ceftin or doxycycline or one of the antibiotics long term, and we would kind of laughingly say they're addicted to antibiotics because every time they go off antibiotics, they relapse. They go back on antibiotics, they feel better again, or go back to normal. They go off antibiotics, they relapse. So far, I'm not aware of any relapses of symptoms after discontinuing of therapy. Now, we've had some symptoms after discontinuing of therapy, but in several people, that's not been thought to be Lyme related. Herxheimer reactions have occurred. I can't really quote your percentage, but it's probably in the range of 10 to 20% of the patients have had Herxheimer reactions. Some of them have been pretty nasty, like when the patient first was treated for Lyme disease. Others have been mild. And then there are a number of patients didn't get any Herxheimer reactions at all. But we see that with any kind of treatment with Lyme. Some patients did not respond. I mean, some patients had zero response. They took it for 6 months, nothing happened. They feel just the same at the end of 6 months that they did before they took it. The reason for the non-response is not clear. That'll be the second part of this talk, which is peptidoglycan, and which you'll understand in a moment. And then it could be due to some other non-Lyme cause. Now, people have said, well, maybe it's a co-infection. It could be, but it also could be viral, could be mast cell activation, could be mold. I mean, there's a long list of potential culprits for the non-response. The other thing we don't know is how long to treat. Is 1 month long enough? If you've killed it off in a month or 2 or 3, obviously 12 months is too long. But if the patient doesn't have any side effects, then no harm done. So we don't know in a human, and some of these people have been infected for 5 to 10 plus years before they were diagnosed, let alone treated. And so we don't know how long these people need to be treated. Okay. Now let's move on to the second subject, which is peptidoglycan, which we'll call BB, which is Borrelia burgdorferi PG. So peptidoglycan, or PG, is a molecular sac that makes up the bacterial cell wall. It's found in almost all bacteria. So virtually all bacteria, there's a few rare exceptions, but almost all bacteria, staph, strep, E. coli, etc., have a cell wall around the outside of the bacteria. And the cell wall provides rigidity and form to the bacteria so that the osmotic pressure inside the bacteria is higher than outside the bacteria, so it won't burst. Now, peptidoglycan, I tell my patients that this is like a brick house or a brick room, and all the bricks look alike. So these are just repeating sequences of this peptidoglycan muropeptide. Muropeptide means it's a peptide or a protein that's hooked up to a glycan, which is a sugar molecule. And there's different amino acid sequences for the protein portion, and then the sugar can vary a little bit as well between bacteria. Now, this next point, the fifth bullet point there, is very important, and that may be one of the keys to Borrelia disease.
Dr. Brewer, do you mean to be moving the slides forward? We're seeing combination therapy versus monotherapy study.
Whoa. Did it go forward? Did it go forward?
No.
Wow. So you don't see peptidoglycan?
No.
But all the others worked okay?
Yes,
Yes.
up until combination therapy.
Did it go
Do you want me
backward?
to,
Yeah.
do you want me to try to move slides?
Yes.
Okay, let me see if I can share them. Oh, I can't share them while the other participant is sharing.
I just gave you
Okay,
that, so I should be able to do it.
it still says I can't.
Do you want me to click out of mine?
Yeah, if you would. If you would.
Okay.
We still have the slides. We can still see your slides.
All right. I'll get rid of them totally.
Judy, if you go down to the share
Okay.
button, does it say
You cannot start screen share while the other participant is sharing.
Stop. Let me just stop share.
yeah, if you would, please.
How about now?
Still see them. Okay, now now I should be able to. Okay.
Thank
Okay.
you.
And now let me get where I need to be. Whoops. Am I?
I think that's where we were, number 10.
Number 10.
Well,
Okay, there we go. Okay. Do y'all see that?
Yeah, that's where we froze.
Okay.
I think you can go slideshow from current slide. If you want to
Okay.
get rid of the
Go
preview.
on down. And can you go to full screen?
Yeah, I'm trying.
Yeah.
There we go.
Okay,
Okay.
now go on down, advance.
Advance again.
Yes. There, okay.
Okay.
Now, does it say peptidoglycan?
Yes, it does.
Okay. So the points that I've already covered, and it's doesn't help a lot to read it anyway. So the fifth point there is that the Borrelia peptidoglycan has a slightly different molecular structure as compared to the peptidoglycan in other bacteria, and that may be the explanation of why Lyme is different. And I'll show you why it's different in a moment. So one of the things that the peptidoglycan does is when it breaks off of the bacteria, or the bacteria is killed or dies, then it gets recycled. It's like recycling some of your trash. So the peptidoglycan gets recycled back into building cell walls for new bacteria. Lyme doesn't do this hardly at all. So when it releases peptidoglycan, either from a live bacteria or a dying bacteria, the peptidoglycan remains as a free molecule not attached to the bacterial cell. And as I said previously, other bacteria don't do it this way. They recycle their cell wall debris. Oh, next slide. Okay, so if any of you heard me talk about this, I talk about dead pieces, and I made this up, so I'm not sure this is in the literature anywhere. So these cell wall fragments, which is peptidoglycan, are dead pieces. These are not, they're part of living bacteria, and then they can exist on their own. So the first study by this group was published in 2019. And they studied Lyme arthritis patients in which their arthritis, this is not just achy joints, this is full-blown arthritis that would be difficult to differentiate from rheumatoid arthritis or other forms of highly inflammatory arthritis. It can be in one joint or can be in multiple joints. And so they studied those patients, and the first thing they found is that they make a specific antibody, immune globulin antibody, that is directed against the PG, not the whole bacteria, but just the PG. And the antibody levels are very high in synovial fluid, which is joint fluid, in the involved joints. And the levels, interestingly enough, for the immune response to the PG is much higher in the joint fluid than in the serum. Secondly, they actually found the PG by itself, free PG, in 94% of the synovial fluid, and rarely found bacteria. I can't remember what the percentage was of bacteria, but I think it was like under 10%. So PG is in it by itself as a free molecule in the joint fluid of Lyme. And these Lyme arthritis patients have failed antibiotics. Their joint symptoms did not get better with antibiotics. Then the next thing they found is that there are high levels of pro-inflammatory cytokines, or inflammation, if you will, are found in the synovial fluid of Lyme patients. And that pattern is exactly the same as what white blood cells produce when they're stimulated with peptidoglycan. So you can take a white blood cell in a laboratory, mix it in with peptidoglycan, Lyme or Borrelia peptidoglycan, and it will incite inflammation. And the same pattern is found in the joint fluid of these Lyme arthritis patients. Now, the next one is my favorite for the joint issues. So they took laboratory mice and they injected them with peptidoglycan. No live bacteria, just dead pieces of peptidoglycan. And it elicited an exact acute arthritis identical to Lyme arthritis. And you say, what do they mean? Well, they mean the inflammation, the biopsies of the joints, etc. Next slide. So this brings us to this group, McClune et al., their most recent study, which is quite fascinating. So this is called the peptidoglycan of Borrelia can persist in discrete tissues and cause systemic responses consistent with chronic illness. So this brings into focus that it goes above and beyond Lyme arthritis, and it could be responsible for some of the chronic symptoms of chronic Lyme disease. Next slide. And then you can see that was just published in April of 2025. So this one's kind of hot off the press. And I didn't even see it in April. I didn't find this article till about July. So in this particular study, they used a specific type of mice or mouse that were injected. So they took Borrelia peptidoglycan, or dead pieces, if you will, and attached them to a fluorescent dye. Then they injected the mouse. And they can actually see through the skin of these mice. You can see the dye light up. So they basically look to where the dye went and how long it stayed around. So they did mice that were injected with the Borrelia dead pieces, and then they did it with mice. They did the same identical thing with mice that injected from peptidoglycan from other bacteria, and the two that they used were E. coli, which is a very common bacteria that causes UTIs and so forth, and staph. So when they used the other bacteria, E. coli or staph, the peptidoglycan was rapidly eliminated out of the body and not retained in the tissues. It was cleared within 24 hours. Not so much with Borrelia. So Borrelia peptidoglycan was retained in the body, with, interestingly, the highest levels being in the liver by far. Liver, they actually in their paper called the liver a sink for peptidoglycan to be retained. And it was retained in the liver for weeks. Now the study only lasted, as I recall, 28 days. So there was still plenty of fluorescence in the liver, not as much as in the beginning. So it did diminish, but it was still present in the liver for weeks after they injected the fluorescing peptidoglycan. And the authors say, not my words, theirs, that it's probably much longer than 28 days. And they think this can hang around for a long time. In humans, we don't know, but it could be a real long time. Next slide. So the other thing they did, this kind of gets back to the inflammation studies. So they took peptidoglycan and incubated it with human white blood cells called mononuclear cells, or peripheral blood mononuclear cells. And again, it induced inflammation. And those are two of the cytokines that are often found in Lyme patients that are elevated. And so basically the simplistic conclusion of this is that peptidoglycan induces inflammation, which had already been shown in the joint studies. Now, the next one is wild, that peptidoglycan impairs mitochondrial function. And of course, mitochondria are the source of energy for cells. So is that why Lyme patients have so much fatigue? It's due to the peptidoglycan impairing mitochondria. The authors, again, not my words, the authors suggest that this is probably the cause of fatigue in Lyme patients. Next slide. So what can we say about the Borrelia peptidoglycan studies? So peptidoglycan, or the dead pieces from Borrelia, has a unique molecular makeup compared to other bacteria, which makes it uniquely different for maybe the pathogenesis of Lyme disease. It does play a major role in Lyme arthritis, which I think has been demonstrated beyond the shadow of a doubt with the the Lyme arthritis human studies and the mouse studies. The persistence in tissues may play a role in PTLD or chronic Lyme. It incites inflammation, causes mitochondrial dysfunction, and may lead to chronic symptoms such as chronic pain, cognitive complaints, fatigue, etc. And again, most of those words are right out of the paper. Next slide. So again, this is a bit repetitive, but saying it a different way, that the Borrelia bacteria releases or sheds peptidoglycan, and it doesn't recycle it. Now, peptidoglycan can be found in active reproducing bacteria, dormant bacteria, and in the next bullet point, dying bacteria. Now, the bacteria could be dying from just aging, senescence, the immune system attack, or antibiotics. And when the bacteria dies, it releases large amounts of peptidoglycan, which brings up the next point. The peptidoglycan is probably the trigger for Herxheimer reactions, because remember, it incites inflammation and impairs mitochondria. It's retained in the body and cleared slowly. We have no idea how long it's cleared in humans, and a spam text, believe that. So we have no idea how long it takes to clear in humans, and there's no urine test or blood test for it. And then, as I've already mentioned on the previous slide, peptidoglycan probably contributes to Lyme arthritis and post-treatment Lyme disease. Now, this next point is interesting, and I think this will be an area for future research. They do mention it in a couple of their papers. There appears to be a difference in individuals on how well they can clear peptidoglycan, and it's genetic, and it has to do with some genetics of the immune system. So that may explain the variations, because some people probably don't get this peptidoglycan effect at all, and other people do, and there's probably a variance on how severe it is. In other words, how much inflammation is created. The next one, I have no idea, but it's an interesting thought, is there a way to enhance peptidoglycan clearance? Some way to detox PG, if you will. And I've looked a little bit, but I haven't found much of anything. Because remember, other bacteria clears quickly. Next slide. So with chronic Lyme and PTLD, or post-treatment Lyme disease, there's a number of conclusions. So this couples everything together. Persistent infection post-treatment is common. Monotherapy with a single drug often fails to clear the infection. Certain combination regimens can successfully eradicate the infection based on a mouse model. Clinically, the combination of cephalosporin and doxycycline is the most useful and practical. And I think we're seeing that with my patients. The duration of combination therapy for PTLD is not known, but looks like it needs to be at least 1 to 2 months. And then lastly, what we just discussed, Borrelia PG is pathogenic even in the absence of live bacteria, and it's at least involved in Lyme arthritis and likely PTLD. Now, I mentioned one other thing, one other paper that, I don't have a slide on it, but that was published around the same time as this PG paper. And that has to do with a drug called piperacillin. Piperacillin is in the penicillin family, and there was a study that showed that it was highly effective at killing the Lyme bacteria and possibly clearing it from the infection. They also use They used test tube testing and also a mouse model. The problem is, as an infectious disease specialist, that's good news if you're working on laboratory research, but it's not great news for patients because piperacillin is IV only. It would be fairly expensive, and one doesn't know how long to have to treat them. And there's probably, again, like I said with some of the other slides earlier, is that there's probably not an insurance company on earth that's going to cover it. So it's interesting laboratory research. That's why I didn't include it in the slide. It's interesting laboratory research, but the patient comes in and says, gee, doc, can you go ahead and put me on some piperacillin? And the answer is no. There's just basically no way to do it. You'd have to put a PICC line in, treat them at home at a huge expense. And it's getting back into the IV treatment for Lyme disease, which didn't work as a single agent. Now, whether this would work as a single agent is not true, but it's just not practical. That's why I've gone with the combination of the cephalosporin and doxycycline. That's all the slides. We'll stop there and I'll open it up for questions.
Okay, let me get to the questions. Okay. Would bicillin IM be an option instead of piperacillin?
No. And the reason is they didn't do a penicillin doxy combination, but I say no with a question mark, but it, based on this study, it must be a cephalosporin that's effective for Lyme and doxy. And I will say that I've had a few patients who can't tolerate doxycycline, mainly with nausea and vomiting. And I have substituted minocycline, M-I-N-O, minocycline, and that has worked in most of them. I have one lady who got nauseated with both of them, and she couldn't do it. But and minocycline seems to have less of a sun reaction too. So I always go with doxycycline, but I leave the door open for minocycline if they have side effects.
Okay. Do you believe that a chronic Lyme patient who took doxy for 5 years, approximately 10 to 15 years ago, and had lots of response, but has had some symptoms reappear, would benefit from the multi-antibiotic therapy?
Possibly, yes. I've had several people who've done that, and at least some of them have responded.
Because the symptoms include the brain fog, chronic pain, headaches, balance issues that make walking without a walker very difficult, pretty much impossible.
It'd be worth a try.
Worth a try. Okay, good to know. Could you do IM Rocephin along with oral doxy, or should they both be oral?
Well, so Rocephin, yes, you could, but it's not necessary. IM Rocephin is painful. It's a very painful injection. IM, that's how I use it IV. But at least, you know, the injectable, the cephalosporins they used in the mouse study were injectable. But the reason is it's a lot easier to inject a mouse than to try to get them to take something oral. Now, the doxycycline was given orally to the mice. So, but in my experience, I think the oral cephalosporins will work just as well.
Since these were animal studies, would human clinical trials be next, you think?
Maybe. I've communicated with one of the authors at Tulane, and I didn't ask her that, but maybe. I'd love to see it, but you know, there's no money in it, you know, since these are all generic antibiotics and so forth. So I'm a bit pessimistic, but I'd love to see it. the other thing is with human trials, since you can't do autopsies, you know, how do you determine if it's eradicated? That's the
Right.
other problem.
How is the piperacillin compared to, I'm sorry, I can't get this to go right. With the ceftriaxone in terms of effectiveness?
Well, I think I pointed out it wasn't included in the mouse study, and it was a different study. So I don't think we can't compare them.
Okay.
I noticed Alan Steer was one of the researchers. Is that the same? Alan
Yeah.
Steer? Okay.
Yes.
Okay. Thank you.
It looks like he's coming. You know, he's a rheumatologist, so I think he's very interested in the Lyme arthritis.
Have you seen sixth nerve palsy as a side effect of Lyme?
Yes. Rare, but yes.
Rare. Is double vision common? And if so, what's the best treatment?
Not common, and the treatment for any of Lyme would be antibiotics.
Okay. Someone had asked earlier, since you are not accepting new patients, are you able to refer us to other physicians? We have a lot of people in the Kansas City area who need help.
That's been a problem. That's been a problem for decades, and it hasn't gotten any better. So I'll have to refer that one back to you. I mean, people are just not, you know, physicians, you know, there's a doctor shortage in every specialty, including mine. And people are not particularly interested in Lyme disease.
Let's see. Yeah, it's about the same question. Who do you recommend for supportive care? How can a patient find out the bacteria has been eradicated? Will a repeated blood test work?
No.
Yeah. Do you recommend infrared lights or red light as treatment?
I know people that have tried it for, you know, joint pains and so forth, but I don't really know much about it. I don't know that I've seen anything where it eradicates Lyme.
What made you get so involved with Lyme disease patients, doctor?
Way back when, this was in the late 80s, early 90s, and I had some patients that ended up in the hospital who ended up having Lyme disease. And one of the very first patients I saw got a bullseye rash while fishing, and he got meningitis and tested positive for Lyme. So I treated him for a couple of weeks with IV antibiotics and said, you know, goodbye, I'll see you in 3 or 4 months, make sure everything's okay. We came back in about 6 weeks and all of his symptoms had returned. So the antibiotics had failed. And I go, that's crazy. That doesn't make any sense at all. So I treated him again, and then ultimately I treated him for over a year and finally got rid of it. But so I basically stumbled into it.
Right. What would your treatment? We have someone here with Morgellons. What would your treatment be for Morgellons disease and Lyme for pediatric patient?
I don't know much about Morgellons. I mean, I know it's been associated with Lyme. I've read about it. I've only seen 2 or 3 or 4 possible cases. I would say, you know, there are some Lyme doctors in other states that kind of specialize in Morgellons, so I would try to seek out one of them.
Okay.
But if a person's just going to try Lyme treatment, you could try the combination.
Who have you? Who can we trust for mold treatment, and do you recommend anyone to your for your patients?
Well, the labs that do mold testing have, I don't know of anybody currently in the Kansas City metro area that's doing much with mold, but the laboratories, there's more than one. I've usually used real time, but there's more than one that they have lists of doctors who are, as well as companies that do testing and so forth. So I would usually have to go out of state for Kansas, Missouri.
Can a patient who saw you some years back still get in to see you?
Well, maybe, but the schedule's so full.
Okay.
Have to talk real nice to my receptionist.
Okay. What do you recommend for biofilms?
I don't know. People have tried all kinds of treatments of enzymes and various detox things and so forth. I don't know. What I do know is that maybe if there is some embedded in some of these hard to eradicate bacteria embedded in biofilm, it appears as though the several months of the combination still works. So maybe it actually works okay on biofilm. And maybe that's part of the magic of why the combination works, because the two together penetrate better than the either one alone. We don't really know exactly why these combinations work.
Yeah, someone commented there are some doctors online who claim their herbal supplements cure Lyme. Is it okay to take those supplements with the antibiotics prescribed?
That's a loaded question, and I'd have to pass on that one. I mean, I don't know which herbs they're talking about. Some of them could be, quote, dangerous, unquote. So I'd have to defer to the doctors they're talking about.
Mm-hmm. Okay. I think I've read through all the questions. With everything that you've talked about, Dr. Brewer, do you feel like that we're making progress in getting treatment and being noticed? We still seem to be fighting an uphill battle.
Yeah, I agree, but that's just the way it is with a lot of diseases, not just Lyme, but a lot of diseases. And but I think this new information is pretty powerful. I mean, I kind of tell my patients that what I just presented to you was basically two major subjects. One of them is really good news on the combination, because it looks like that we may be able to cure Lyme disease in certain individuals. And the peptidoglycan is not that good of news, but in a way it is, because it explains why some of these people can take enough antibiotics to sink the Titanic and they just don't get better. And it may be the peptidoglycan. And if, the groups that does the research on the peptidoglycan is not just going to drop this and go away. I mean, they're going to study it and see if they can find some way to either combat the inflammation or to clean out the peptidoglycan. So I think more is going to come on that. Remember that mouse study with the fluorescing dye was published in April. I mean, that's a brand new study. Yeah. So I think a lot more is going to come. So I think both of these subjects open the door for a lot more Lyme research, and I am glad that people didn't give up on the research. Most of this is mouse study or test tube research, but I'm glad people didn't give up.
Okay. Are you okay with us posting the PowerPoint slides on our websites as well?
Yeah, that's fine.
Okay. And everyone appreciates.
And that's
updates.
actually a good way to get the information out there. So I'm more than
Yes.
happy to have those posted because it gets information out there, and I think it flows pretty well to reasonably easy to read, and particularly the conclusions. And so, maybe we'll help somebody who can go to their doctor and say, if I could I try this simple, safe combination for a month or 2 months and see if I get better. And some of you have heard me say this, and I have people who walk in and say, "Doc, I'm cured."
Mhm.
And I almost never used to hear that. Not very often anyway. I'd point out one other thing, to me two things. Remember the placebo group. The mice are all infected. Well, presumably the same thing happens in humans. And
Yeah.
the human immune system is very similar to the mouse immune system. And so it raises the question of how many people are there out there with Lyme disease, some of which may not have any symptoms, at least now. The other thing I'd say is that if one gets a tick bite that's very worrisome, particularly a tick bite with like a bullseye type rash or that sort of thing, rather than take a single agent, I myself would take a combination for 1 month. And if we would have known this 25, 30, 40 years ago, we probably you wouldn't even have a group now. That's my opinion. I don't know that to be true, but that's my opinion.
Well, I know earlier you said the single IV didn't work. It got my brain back, but I was on other oral antibiotics. So maybe it was those other combinations with the Rocephin that helped get most of my brain back. And
Yeah, I'm sure that I knowingly or unknowingly cured people and didn't know that
yes,
didn't know why.
yes, but I know definitely you've made a huge impact on my family, and I appreciate everything you've done.
Well, you're welcome.
Doctor, how long do you have to wait after symptoms are gone before you know that treatment has been effective, would you say?
I would say, probably 6 months to a year, although I'll just give you one example. I had one of my earliest cases. She only took the combo for 2 months, but her history was, so she used to basically live on ceftriaxone. And if she took ceftriaxone, she was pretty close to normal, maybe not 100%, but pretty close to normal. And but if she'd go off of the cefton, she would relapse, and she tried going off of it probably over 5 times over the years, maybe even 6 or 7 times. And if she'd go off, she'd always 100% of the time relapse in 2 weeks. Always relapse in 2 weeks. She could make it about a week and think, oh, maybe this is going to be the time. And then that second week, all the symptoms would kick in and she would relapse. So she took it for 2 months, and that's probably been 8 to 9 months ago, and she's had no relapses.
Mhm.
And
What about?
she feels
go on.
normal. She feels normal.
That's great. What about those of us who are allergic to cephalosporins and penicillins? And I know the combination of the doxy and the cephalosporins. Are we out of luck, or?
Yeah, there might be I'm not willing to do it yet, but there were some other combinations. They're very dicey. That dapsone and
Right.
all of those drugs have side effects. One of them's not even on the market. Another one you have to get through CDC. So, but there may be some possibilities there. I mean, because in the laboratory, I mean, so not in the laboratory, in the mouse, they worked. They work just as good as the others. So there might be some rare circumstances where those could be used.
Okay.
Remember, this is all pretty new.
Right.
I've only been at this a little over a year for the combinations.
What are the strengths of the Ceftin and the Doxy for the combination therapy?
Ceftin is 500 milligrams twice a day, and Doxy is 100 milligrams twice a day.
Okay. And do you think if a person who reacted years ago to those, like I was saying, penicillins and cephalosporins, because I know they're cross-linked, would they still be allergic to them today?
They may not be, and we see people all the time who the allergy kind of went away, if you will. So, and you can always maybe go see an allergist and see if you could be tested.
Okay. All right. Are you still using the same protocol for Marcone's?
That's a separate subject. That has to do with mold.
Okay, someone was asking that question, so okay.
That's
All
not
right.
related to Lyme.
Okay.
All right.
Well, thank you, Dr. Brewer.
Thank you. I hope that was helpful.
It was very helpful. We appreciate it.
Take care.
Okay, thank you. If you want to stop the recording now, Kurt, I don't know if